Good morning, and thank you for the invitation. Well, thank you, Dr. Samir Alam. Felen, your lecture was very enlightening, and I learned a lot from your lecture about the IFR and FFR in the management of coronary artery disease. So thank you very much for being with us this morning. And I will come to the defense of coronary CT in general, and in particular in the management of patients with left main disease. One of the first slides that Dr. Samir Alam was of a patient with a very significant bright coronary stenosis that he said was missed with CT. And he also stated that the left main lesion was also missed by CT. Well, this is not, I don't think this is the problem with the technology. This is a problem of the operators and also the interpreters. And this is why looking at CTs and interpreting CTs requires a lot of experience. It's not like looking at coronary angiogram. So what is the role of CT in the diagnosis of coronary artery disease, and as I said, in particular, left main disease? This is the latest recommendations by the NICE, the National Institute of Health and Care of Excellence in the UK. And as you can see in the evaluation of stable patients with coronary artery disease, they advocate the use of coronary CT as the first diagnostic modality in looking for or diagnosis coronary artery disease. So that reflects the trust in this technology in making a definitive diagnosis of the presence or absence of coronary artery disease. And also the Ischemia Trial, which was alluded to by Dr. Samir in the previous lecture. As you know, the Ischemia study was designed to randomize patients to an invasive strategy versus conservative strategy and to see if any of these two strategies is superior to the other one. I'm not going to discuss this, but I'm going to discuss how it was done. They took patients with stable coronary artery disease, and they had to have by design moderate or severe ischemia determined either by the presence of ECG changes or the presence of positive stress tests. And all of these patients had to have a blinded CTA. So the first test that was done on these patients for inclusion in this trial was a coronary CTA. And again, this also reflects the trust in this technology in defining not only the presence or absence of coronary artery disease, but also the significance of coronary artery disease in these patients. And then if these patients were screened and they were found to have significant three-vessel disease or significant disease, excluding left main disease, they were randomized to the particular therapy. Now, you have to know that some of these patients they failed screenings, they were excluded from the trial, and those patients, those who had insufficient ischemia or those who had no obstructive coronary artery disease and those who had unprotected left main disease. My point here is that CTA was used to rule out or rule in the presence of left main disease. So this is, again, how much trust we have in coronary CTA to make a diagnosis of not only peripheral coronary artery disease or coronary artery disease in the LAD or the circumflex right coronary artery, but also in the left main disease. The recently published Syntax 3 Revolution trial, also in that trial, which was presented in the PCR and also was published last year, this trial was designed to determine the agreement between two heart teams. A heart team was formed by a cardiac surgeon, a cardiologist, clinical cardiologist, and a radiologist on treatment recommendations and planning based either on coronary CTA with or without FFR CT or conventional angiography. So there are two groups of patients. These patients, they all had three-vessel disease with or without left main disease, and they all underwent conventional angiography. So they all had invasive angiography, and then they all had coronary CTA on a GE machine. And then they were randomized to two heart teams. The first heart team, Team A, looked first at the invasive coronary angiography. Heart Team B looked first at the CT. And these two teams, including a surgeon, an interventional cardiologist, and a clinical cardiologist, they tried, their job was to make recommendations based on the first test that they saw, which was in Team A, the coronary angiogram, and in Team B was the CT. So they looked at the coronary angiogram here, and they also incorporated the Syntax 2 score, which includes anatomy and also comorbidities, and they tried to make those recommendations. And then after they've done their recommendations, they were giving the CT angio information, and they wanted to see if the information provided by CT would have changed their recommendation. The opposite was done by Team B, in which case they first looked at the CT angiogram, and then they tried to make recommendations based on the CT angiogram, the anatomical assessment of coronary arteries, and they incorporated the Syntax 2 score in that. And again, they also incorporated the FFR-CT in that. And finally, they made their final recommendations based on what they had. They also were provided with the invasive coronary angiogram at the end. So the idea behind the Syntax 3 trial is to see if coronary CT, a non-invasive test, can provide an accurate assessment for the presence of coronary artery disease functionally and anatomically to the extent that surgeons and interventional cardiologists can build their recommendations based on that. This is just an exemplary case from the Syntax 3 trial. This patient had a coronary CT. As you can see here, the right coronary artery was normal. The LAD did not show any significant lesions. There were some calcified plaques in the proximal LAD, but there was no stenosis. The circumflex artery was also normal, but there was a tight lesion in the distal left main, which was very obvious on the CT angio. This patient had also an FRCT, and the FRCT correlated very well with the presence of the anatomic stenosis in the distal left main, with a significant drop in the FRCT to 0.54 in the LAD, to 0.55 in the circumflex, showing that the stenosis in the distal left main was hemodynamically or was functionally very, very significant. So this is how a patient on the CT arm was worked up. So what did the trial show? This is maybe a bit complex to understand, but if you look here, these are the recommendations of the first heart team that based their recommendations on conventional coronary angiography. And if you look at bypass surgery, it was recommended in 26.1% of the patient. When heart team B, which looked at CCT first, made their recommendations, they also recommended bypass in 27.9%, very close number, 27.9 and 26.1% of the patients. When they looked at PCI or equipoise for bypass and PCI, in the first heart team, the recommendation was given in 73.9% of the patient, and it was given in 72.1% of the patients, depending on the findings on the coronary CT with functional assessment. So again, very close numbers. So both studies, agreement between the heart teams for recommended treatment using either CTA or conventional angiography was almost perfect. There were no changes. CCTA evaluation with FFRCT was feasible in patients with multivessel disease in 87.9%. The doctor here mentioned that FRCT is a kind of difficult. The most important caveat is that you need a good study. If you have a good study, then you can perform FFRCT. Now we have to send the data to the USA, as he said, but in future, I think all vendors of CT machines will have the software incorporated in their machines. You'll be able to do it on site, so you don't have to send it anywhere. And Dr. Samir Alam said that they are working in software to do that in their centers. I hope they can provide us with a copy once it's ready. So the inclusion of FFRCT changed the treatment decision in 7%, so it did not provide a lot of input in management-wise. The results support the potential role of non-invasive imaging with coronary CTA for treatment decision-making and planning in patients with left main disease or three-vessel disease. So I can envision a day, which will not be too far, where we will solely depend on non-invasive assessment of coronary arteries, not only to recommend or to base our recommendation for PCI, but also to base our recommendation for bypassing these patients. And coronary angiography would probably not be required in the majority of patients for diagnostic purposes. So what about the value of CT in the assessment of osteal lesions of the LAD? Now this is a very difficult clinical problem. If you have a patient who has this left main and has a significant lesion in the proximal and the ostium of the LAD, now it's very important to determine whether the plaque is only limited to the LAD or you have extension of plaque into the left main. Looking at the angiogram here, it's very hard to tell if you have a plaque in the left main or not. This is very important because you need to know as an interventionist whether you need to stent only to the ostium of the LAD, skipping the left main, or you need to cover part of the left main in your stent. So what we usually do is, what most people do is they resort to doing an IVUS in these patients, and in this patient you can see that there's a significant plaque in the proximal LAD, but there was no plaque in the, or there virtually a very minimal plaque in the left main. So it was safe, it is safe in this patient to just stent the LAD and not stent the left main. Let's face it, not all people have IVUSs in their labs. It's an invasive test, it's kind of expensive, and even if people who are dedicated operators who do a lot of left main disease, they don't even do IVUSs in the majority of patients when they do their left main stenting. So this is in contrast to this patient who also has a significant disease in the proximal, in the ostium of the LAD, and this patient also has a left main that looks almost exactly like the left main in the first patient. But here you can see that the LAD disease is extensive. There's a large plaque burden in the ostium of the LAD, and also there's a significant plaque burden in the distal left main. This patient will need to stent from the left main into the LAD, a totally different procedure than the first one. So IVUS helps, but then CTA, coronary CT, can also be of great help in these patients. We can see plaques. With coronary angiography, you can see lumen. With CTA, you can see the wall of the artery, and you can really judge what type of plaque the patient has. Dr. Sami told you about the high risk, the presence or absence of high risk plaques, but we can also tell the extent of the plaques in this patient. There is a definite plaque in the proximal LAD that extends partly into the left main. This patient who has a very tight subtotal occlusion of the LAD, you can see that the left main is completely normal. So when you stent this patient, you can stop at the ostium of the LAD. You don't have to stent the left main. This is in contrast to this patient who also has a ostial LAD lesion, but you can see that the plaque extends into the left main, so this patient will require a stent that extends from the left main into the proximal LAD.
Yeah, I think it stopped the presentation because...
Stop the presentation, stop. What do I do?
Conclude.
I have 2 more minutes and I will finish.
Okay.
Okay, so another area which is also important in the in patients with coronary heart disease is the diagnosis of congenital anomalies. This is a patient with separate ostia. The LAD is originates separately from the circumflex. This is a nice information to know when you perform your cardiac catheterization, because sometimes you can erroneously miss the presence of the other coronary, assuming that maybe it's totally occluded. This is, of course, a benign condition, has no consequences. Another condition that you can easily diagnose with coronary CT is when you have an anomalous origin of the left main coming from the right coronary sinus instead of the left coronary sinus. In this case, the left main passes posteriorly, so this is also a benign condition. It doesn't go between the aorta and the pulmonary artery. In contrast to this patient where the left main also originates from the right coronary sinus, but this time it passes between the aorta and passes between the pulmonary artery, and this is a malignant condition that warrants intervention in the majority of patients. The final issue is stent assessment. We're all in favor of stenting left main coronary arteries if we can. We always try to avoid surgery, and the way we evaluate, we do that with stenting. Now, there is a problem with evaluating stents in coronary CT. If you take in consideration the low spatial resolution of coronary CT of about 0.5 millimeters, couple that with the motion artifacts that can be induced by cardiac motion or by patient's movement, you can imagine that it's almost impossible to have good assessment of stents that are smaller than 3 millimeters in diameter. But if in the left main artery, the problem is much easier. This is just to show you a stent, a coronary angiogram showing very severe in-stent restenosis, and it can be seen very clearly when we do a CT angiogram, but this is, you don't see this in all cases. But in the left main is a big artery. It's usually in the range of 4 or 4.5 millimeters in diameter, and it's not subject to the severe motion that we see with peripheral, with the other coronaries, because it's very close to the aorta, which is a stable organ in the chest. So you can can very nicely, very accurately assess stents. You can do that post-procedure, and you can do that when you do follow-up on these stents. You can look at the perfection of the procedure, and you can also assess for the presence or absence of in-stent restenosis. With that, I end. I apologize for exceeding my time, but thank you very much for the opportunity.
Thank you, Dr. Ramzi, and I'm sorry we have been really behind schedule for quite a time. So we'll conclude this session without taking questions. If anyone has a question, he can address Dr. Ramzi directly. Thank you.